they actually projected in slide view?
Yeah, no, I've got it. It looks perfect to me.
Okay, great, thank you. Now, is it gonna let me? Okay, there we go. So just some disclosures, because I work with biomedical data. So I don't really have anything to disclose. I don't have any fancy money from industry. Everything I have is from the tri-councils, from the government. Um, and so I show this slide a lot about my lab to talk a little bit about what we do. So before I was at Queen's, I was on the faculty at Memorial Sloan Kettering Cancer Center in New York, and I spent a whole lot of time working with biostatisticians. And so for me, like applied stats is where it's at, and I love the applied statisticians. So I'm really happy to be here. So we do a lot of work in biomarker development, which is this top right quadrant, and that requires a lot of work in repeatability and reproducibility. So the idea that you want to make a robust biomarker that you can roll out to different patients and that it actually works in a repeatable and reproducible and expected way every time. And so I used to show this slide a lot because people would say to me, well, what's the difference between what you do as a computer scientist and what does a biostatistician do? And it's funny, if you talk to the machine learning people, they say, well, this isn't biostatistics, blah, blah, blah. But in fact, of course, there's so much overlap between the communities, right? So that's why I love this group and I'm happy to give a talk. Um, so I'm going to talk today just a little bit about radiomics, quantitative imaging. I'll give you an example of that, and then talk about repeatability and reproducibility within that. And I think this is a good adjunct to some of the other discussions that you're having today, because you can see some of the actual data that we have and how repeatability and reproducibility come into play. And so radiomics is the idea of high throughput extraction of quantitative features from radiographic imaging. And these are usually explicit features that have to do with texture and shape within that image. And then we also talk about radiogenomics, which is the linking of radiomics with gene expression data, either as a predictor or as the predicted. And so there's lots of work in radiomics that you can look at. This is one of the classical papers, and it's really based on this idea that when you're extracting these features from images, that in fact what you're doing is making observations of the clinical imaging that reflect some kind of biology. So it's not just random data that you're looking at. It actually reflects some kind of tissue level dynamics, and this is what you're actually looking at. And it's really this idea that images are more than pictures, they're actually data. And for decades, we've considered radiology imaging to just be pictures, and really what we're talking about is turning it into data, to robust biomarkers. And so in the radiomics space, we think about, so on the very left of your screen, those are lung cancers, and so we can apply segmentation to those, and the green thing is the actual segmented tumor. So I think you can appreciate that each of those different patients has a very different looking tumor, and we can extract features from these things and combine these features with other information. It might be clinical information, it might be gene expression data. There's all kinds of different things that we could combine this information with. And so typically you start with an image, you do some kind of image segmentation, so you actually find where the tumor is. So this particular image is a pancreas cancer, so we've extracted that pancreas cancer, we've created a 3D stack of those images, and then we extract some features, and then we create some kind of prediction model off of this. And the idea is that you would actually use these prediction models to stratify patients for surgery. So to select patients for surgery or for chemotherapy and that kind of thing. And so, obviously the need for reproducibility in this context is pretty great. To dig into some of the actual math of radiomics, so one of the most popular pieces of radiomics is something called texture analysis. And texture analysis is the idea that when you look at an image, you can actually study the relationship between the pixel patterns. So, if you zoom in onto an image, you can really see those pixel patterns and you can study how they vary, and you can actually encode that. And one of the ways that we have of doing that is to look at neighboring pixels using gray level co-occurrence. So you can it's basically an adjacency matrix that you can generate based on images, and then you can actually extract statistical features from those images. And these were created in the 1970s. There's probably 1,000 that you can extract, and they're based on different mathematical formulations of the features that you're taking out of these matrices. And there's different types of matrices you can construct, and we don't have to go into all those, but there's just to say that there's a whole world of this, right? And like I can make new features, I can define different math to be able to do this. So here's another example. We can look at self-similarity within images, which are called fractal features. And there's, 1,000 fractal features that you can extract from images. And so let me give you just an example of something that we do with radiomics to kind of drive home the point that it's an important thing. So in patients that are diagnosed with colon cancer, the patients that die of colon cancer typically die of colorectal liver metastases, meaning that they have a colon cancer that spreads to their liver and then they become untreatable. And so what we're really interested in is treating the patients and predicting the patients that will respond to chemotherapy. Because if we know the patients that will respond to chemotherapy, then we can do a better job selecting them for that therapy. And there's no way really right now to predict which patients will respond to a given therapy. And so we have a big program, lots of funding from the National Institutes of Health to look at this idea. And this is just one small study that we did as preliminary data to show that if you extract tumors from imaging and then you extract these features, you can actually train models to predict volumetric response to chemotherapy. So here we have a training set and a test set, and you can actually make a really, really nice prediction showing that just off of one image, you can figure out whether someone will respond to cytotoxic chemotherapy. And so this is pretty big in cancer. Lots of people have done this for different types of cancers. And so we know that things like having more heterogeneity in the image means that you'll have a better response. And there's some genetic reasons for that. So let me just switch now to talking about reproducibility and repeatability within this. Okay, so this is a CT scan of the liver. If we zoom in on this, so this is what I talk about when I'm talking about pixel variation, right? Like these pixel values represent real biology. And so if you kind of start going through, like, what does that actually mean? So when you're a patient and you're getting a liver CT scan, you're laying in the scanner, X-ray is spinning around your body, right? We are injecting you with intravenous contrast. That intravenous contrast is leaking through your liver. So that's changing what we see in the CT scan. So that is changing how the liver is highlighted in the CT scan, how the vasculature is highlighted, and it's highly dependent on the leakiness of the vessels that you have in your liver. And it's also dependent on their leakiness. It's dependent on the properties of the liver that have to do with health, right? And so all of these things are happen, but they're also dependent on the machine that you're imaged in. It's dependent on the manufacturer of that machine. It's dependent on the variation in the contrast timing. So what we do is we inject you with contrast and then we wait. And we typically wait some amount of time, and that totally varies by the hospital that you're being imaged in. And it's somewhat standard across different hospitals, but here's an example of two different scans. This is the same patient taken 10 days apart. So your cancer really doesn't change that much in 10 days. So one is a scan from an outside hospital, and the scan on the right is from Sloan Kettering. And you can see just a totally different view of this thing, right? So you can imagine that if I now extract statistical features from this image, they are going to vary drastically between these two scans. And so how do you deal with that? How do you deal with that? And so we've done lots of retrospective studies where we've taken data of patients that came through the hospital, and then we looked at patients that were scanned for whatever reason multiple times, because when you have cancer, we just scan you all the time because we want to know what's going on with your cancer. So we've done all kinds of stuff looking at variation in scan protocols, but it's impossible to do because you don't get all the permutations and combinations of these acquisition parameters. And so what we decided to do was to create a prospective study to really carefully capture all of these different variations so that we could actually study them. And then what we also did was we made sure that they were all patients of the same type, meaning that we picked all of the patients with the same type of cancer. We picked them at the same stage of disease. And what this means is that not only can we assess repeatability and reproducibility, we can assess that on the model that gets generated, the predictive or prognostic model that gets generated off this data. So what we did, so when we scan these patients, you get a scan. So we do a CT, and then we inject contrast, and then we wait, and then we do another one. And so these scans only take 2 or 3 seconds, right? It's not like an MRI scan that takes 10 minutes. So we give you a scan, we give you some contrast, and then we scan again. And so the second scan is at 80 seconds at Sloan Kettering. And so what we did, so this is your routine scan. So we added another scan. And so we did this across 50 patients, and we varied the timing of that second scan. And so we added this within minus 15 to plus 15 seconds of the routine scan. And you can do this because CT is very fast. And so it only takes a couple of seconds, right? So to add another phase is not that big of a deal. And so then what we did was we varied how we reconstructed the scan. We varied how we acquired some of the other parameters within this study. And then we did it at 2 different sites. And so what you essentially have is a systematically designed study where you can capture differences in image acquisition, differences in image reconstruction, inter and intra scanner variability, so scanners within the same hospital versus scanners at outside hospitals, differences in tumor variability, right? So patients have multiple tumors, so you can start looking at variability across themselves and across the whole cohort of patients. And then, like I was saying, you can actually look at the influence of these on the variability in the prediction that we get to try to close the loop on reproducibility, pardon me, in the models that we actually design. And, you know, this is very much like a computer science, like engineer design this study, right? Like you take all the things and you turn the little knobs a little bit until you get what you need. So, but this is how we approached it. And, you know, so the reason I wanted to do this talk was so that we could talk about this concept. But we've also been, I've been writing this paper with a biostatistician thinking about sources of bias and looking at things like incorporation bias, verification bias, spectrum bias, which are all aspects of reproducibility, right? That when you have these sources of bias that are within your studies, they are going to prevent you from making a biomarker, in our case, that's reproducible, that somebody else can actually use as well. And so it's been really fascinating to work through with the biostatistician and talk about, like, one of the most common things we do in imaging is actually incorporation bias. So we always take images and make a prediction, and where the prediction is based on imaging. And so if you're predicting recurrence, and the recurrence is actually defined in the imaging, so you get this circular concept. We do this all the time in imaging, image analysis. People don't see anything wrong with it, but in fact, this is perhaps not the right thing to do. And this is when I presented this a few weeks ago to an imaging community, they were like, "What? We're not supposed to do that?" But that's what we do all the time, right? And so going through some of these things has been super fascinating. What else? And then one last thing. So the other reason why I'm interested in doing this is because, you know, we all have one of these in the province. Mine's pretty old. I haven't updated it yet because of COVID, but we all have this number that's assigned to us in the province in terms of our health data. So there's a new health data platform that has come to Ontario called the Ontario Health Data Platform, where we're federating the health data. And this includes and will include in the future imaging data. And so all of these things that you're talking about today in terms of reproducibility really directly impact how we generate robust models with health data. And so I just wanted to put a plug in for this thing because I think it's going to be amazing and terrifying all at the same time. And that's it. Thank you.
Thanks, Anna. That was really interesting. I always love your presentations. I noticed a few sort of biostats folks joining us, so I might just call them out. So if you're a biostats person, if you have a question, but if anyone else has any other questions, please just add it to the Slack or the chat. I'll just start while I give the biostats people a chance to think about what they're going to ask you. Jesse, I'm talking to you. With the federated, what's going on with the federated data platform? I'm super excited about it.
Yeah,
last time we talked, it was sort of very early.
Yeah, so it all the data is in place, and now all I do now is go to meetings with the Ministry of Health about the platform. But soon it will be active. So I actually, my group should be the first ones on the high performance compute part of the platform, which is actually hosted at Queen's, although it's Ministry of Health, anybody can access it. And that should be in 2 weeks. The number of contracts that have to be signed as a result of this thing is enormous. But once we get it through it the first time, everybody else will be able to access it. So
how will people manage the whole privacy budget issue? Let's say your team makes one contingency table and another team makes another one and another one makes another one. Pretty soon we'll know exactly who these people are.
Yeah, and so this is so it's funny. So when the Ministry of Health is thinking about doing these things, they're not savvy in those ideas, right? So they don't understand, or they didn't in the beginning understand, that any data is potentially identifiable. And so the reason why they created this platform, so it's actually a secure platform that you have to log into, and you have to be a trusted researcher or the team member, right? Like all my students can go on. So you have to be a known quantity. You have to apply to be on this thing. They give you the cuts of data that you need for your project. And so you can't take anything out of the platform. There's no egress, which is fascinating to work through as well, because you don't have cut and paste. Like how do you do anything in R without cut and paste? So, this platform has R installed. It has anything you'd want, really. Like it's got Python, it's got, Jupyter notebooks, all this kind of stuff. But basically, for the first time, the government has taken responsibility for leakages of data by providing this platform, which historically it's been on the researchers, which is why we're all terrified to do it, right? Because we're the ones that will get sued. And so that's what's really exciting. And because the Ministry of Health, they are the owners of the data or the custodians of the data, they can do this, right? Whereas if U of T decides they want to do something, well, they don't technically necessarily own the data. So by the governance being taken care of by the Ministry of Health, it opens up a lot of this possibility.
Jesse, did you have a question by now? No, I'm just trying to look and see who the other bio folks are. Lisa, did?
I mean, I could jump in again. I mean,
I think Lisa may have been.
Okay, yeah.
Oh, no, actually, I missed the first part. I'm sorry, but I wish I didn't.
Patra is asking on the Slack, is there a protocol for underrepresented groups in these sorts of data, and how does that affect the analysis?
Yeah, that's a great question. So I have a New Frontiers grant to look at how that affects some of the work that we do. And you might know, she's actually from U of T, Lana James. So she's from Ready for Black Lives. So I actually just recruited her as a postdoc, and she started January 1st. And that's something that we're getting into. So Lana is amazing. And if you haven't gotten her to give a talk, you should. So she she has changed my worldview about data. So data is biased, right? And we hear that, but we don't always feel it in our bones. Like I have always thought that there is perfect data out there and that we just needed to get the data perfect. And if we get the data perfect, everything will be fine. That is not true. And there are specifically medical data that there are variables that are assigned race inherently in a very odd way that I had no idea existed until until I got to know Lana. So the whole race-based medicine, and actually it's not even race-based medicine, it's racist medicine. Like it's straight up racism in medicine, and you see it in the data. And so figuring out how to get past that is the topic of a lot of really complicated conversations that have to happen. But I think like I have hope that we can do this, but there's also this piece of data sovereignty that I think we have to really think through. And you know, I'm white and I benefit from the data because the data is all based on us, right? And so understanding that if you want to bring in and you want to ask questions of Black and Indigenous populations, you really need to engage them and in a real way where you can actually understand the data better, which I think is what the data sovereignty movement aims to do, which it's so fascinating. Like that they can actually look at the data and say, oh, well, you know what, if you actually included these other variables, you would get at that thing that you're trying to get to. And so I definitely recommend, I'll put it in the chat, actually, a link to one of her podcasts, but she just graduated from U of T, or she's just graduating. So she's fantastic.
Oh, thanks for that. I think Patra might like to follow up. Patra, did you want to just?
Thank you. Yes, I understand the concern about race, for example, indigenous groups, but does the same protocol apply to people with specific conditions? For example, in my own case, I live with a bone condition that my bone density is way higher than the normal. So if I participate in a study, probably you will need to exclude me because otherwise it's like including Wolverine in the study in super raw terms. Am I being clear with the question?
Yeah, so I will answer that even more broadly.
Okay,
so when we consent you for any clinical trial, there are inclusion and exclusion criteria, and we have no idea how a treatment actually performs outside of that inclusion and exclusion criteria.
Have I lost my connection, or have we lost?
No, I think Amber's connection.
Okay.
Oh no.
That's right. We'll just ask her to follow up when she's back. The outliers, it only takes a different meaning in the EHR or electronic health record. Yeah, EHR data sets, right, Patrick? Because you're like, well, actually, each of these outliers is probably a person. We normally just throw them away fairly happily or not worrying about it too much. And then, but with the EHR data, it's all people. It's quite a concern. Yeah, Sylvia, that's certainly with the COVID vaccine, right? We have no idea with the pregnant folks. Speaking of children, sorry, my toddler just ran in. So. Lisa or Jesse, from a Biostats perspective, did you have anything you wanted to add? We've got 3 or 4 more minutes.
I mean, definitely, I work in genomics, so it's definitely a big issue for us as well. Obviously, we can estimate genetic ancestry from the genomics data, and I would say one of our biggest challenges is that there really aren't great statistical tools to analyze multi-ethnic populations, admixed populations, and so I think it's a big area of needed statistical development.
Yeah, I think so. I work with electronic health records data. I too missed the beginning of the talk, so apologies. But I think some of the questions asking around basically bias and fairness and how we evaluate those things, especially in Canada, I've recently found race and ethnicity for the most part isn't recorded in the health record. So then even using this data downstream is a huge challenge. So, yeah.
Amber, I think you might be back.
I'm back.
We
I
missed
caught-
you you were in mid gesticulation, so it was very exciting. But the context of the question, I think Pasha was sort of following on, and you were talking about
Yeah.
inclusion, and
Yeah.
we've got a few more minutes if you wanted to finish off.
I was going to say, I just heard part of the discussion that just happened. So one of the things that Lana taught me about was, so there's a laboratory value, like a blood marker that you get. And when she gets her report, it says adjusted for African-American status. So she's neither African nor American. So, okay, there's that, but okay. So they actually adjust it. And so even though we until now, we're not explicitly collecting race data in Ontario, we were still adjusting laboratory values. And that is the same laboratory value that they use to make very critical decisions about how people are treated that have heart attacks. And so so that is straight up racism, right? Like we are actually the same, like my heart functions the same as everyone else's heart. There is no need to adjust that variable. And that's what I mean when I say that the data is inherently biased. It's literally biased. Like it's literally somebody going in and adjusting a measurement. It's done automatically, right? It's done automatically by the medical devices that are used to acquire the data. But nonetheless, it happens. And so, this group, like your data scientists, so you hear that and you're like, that's crazy, right? But that's what happens in medicine all the time.
Right, just say thanks once again for an amazing presentation, Amber. It was just so informative. I always feel that I understand biostats after your talks, and now having given talks, you realize how much work it takes to bring the audience with you, so that they feel that way, rather than leaving them feeling as though that you're the biggest genius there is, even though you are the biggest genius that there is. So thank you very much for bringing the audience with you, and a wonderful talk. Thank you.
Thank you. I'm going to paste a link to that podcast. It's the Stanford Health AI podcast, and Lana did an episode. And then she's also done other work that's super fascinating that I highly recommend. Thank you, Rohan, as always, lovely.
Thanks so much.